Hello, and welcome to another episode of Boundless Body Radio. I'm your host, Casey Ruff, and today we have another amazing guest to introduce to you now. Dr. Vyvyane Loh is board certified in obesity medicine and internal medicine. She graduated from the Boston University School of Medicine and trained at Newton-Wellesley Hospital, where she also served as chief resident. Dr. Loh worked at HMR and was the medical obesity specialist at the Newton-Wellesley Hospital Center for Weight Loss Surgery before starting her own practice. She is a member of the Obesity Medicine Association and the Obesity Society. Her other achievements include choreography and writing. She was the recipient of the Bunting Radcliffe Fellowship in Fiction in 2006, a Guggenheim Fellow in Fiction in 2008, and shortlisted for the 2005 International IMPAC Award in Literature. Her diverse skills support her commitment to celebrating the full range of our humanity in an increasingly technological and disembodied world through art and the healing scientist. She is also host of the amazing VLMD Rounds Podcast. Along her professional journey, she realized that much of her healthcare industry that she was trained in is in reality a sickcare industry. And Dr. Loh is striving to change the paradigm of weight loss and obesity. Dr. Vyvyane Loh, what an absolute honor it is to welcome you to Boundless Body Radio.
It's wonderful to be here.
Well, I'm really glad you had a little bobble too. There's a first take that nobody's going to hear where I really screwed things up. Almost got through until we were talking about your podcast, VLMD. I really wanted to get that round, the VLMD Rounds Podcast.
Just my initials,
What an amazing podcast that is.
Thank you. I put it out there. I just started in September of last year. And I didn't know whether it was helpful for people. As I told you earlier, I'm just making an episode every week. So I hardly have time to look back, take a breath and dive into the next week. But my main, aim is to just have a wider look at metabolic health and to have more serious dives into the field of metabolic health, because we hear these topics discussed all the time, but sometimes it can get fuzzy. And so clarifying maybe some of the basic concepts to get everyone on the same page, I think might be helpful.
It is very helpful. The episode you did about sweeteners, I know that wasn't even your favorite to do because it's so complicated. You made things really easy for me to understand. And I really appreciated the deep dives into these things. And the funny thing is, I say deep dive, you will finish an episode and be like, I'm so sorry. This was like very, very high level. I wish I could get into more details. This is after talking for like an hour and a half. You're like, oh, I'm sorry, this isn't enough information. Like, what are you talking about? This is amazing.
Thank you. I think that's the challenge for me because, I basically only have roughly an hour or so. Sometimes I run over. And then I am not sure what people know or don't know. Trying to manage an audience that might be relatively new to some of the topics, and then some people who might really, know a whole lot more. And it's really hard to kind of present something to a general audience and then also to a specialized audience at the same time.
Yeah, no, and for that person who maybe isn't understanding some of the more complex subjects, I would suggest going to the very beginning and start from there, because it does seem to be a little bit more like user-friendly in the beginning, and then you get into more specific topics as you go. And I really appreciate one of the things you said after one of the interviews, or one of your episodes, where you said, like, somebody asked me what we're going to talk about when I run out of topics. Like, we're never going to run out of topics. It's so fascinating. We can always find something to talk about.
Yeah, we're talking about the human body. It's just every day, I just feel like, oh my God, it's overwhelming, the things that we're learning every day, right? And so as cool. I said earlier, we're really making a lot of discoveries in basic science. And really now, I wish we could translate a lot of those discoveries into clinical practice. I think that's where the work is.
Yeah, I'm so excited to talk about that with you today. Your time management skills must be of all time great as far as what you're doing in a day. You do dance, you do writing, you're writing multiple books, podcasting, you've got your clinic, like so busy. Plus you're working out, you're meditating, so many things you always have going on. I don't know how you do it. It's really wonderful.
It's called hustling, Casey. You just
Good
hustle.
For you.
Yeah.
Good for you. I love it. I love it. I can totally relate. I want to talk about your schooling that you got at college. You had a very unique opportunity. Can you tell us about what college was like for you?
Yeah, so I attended Boston University as an undergrad. And at the end of my freshman year, there was a special program that they offered, and it was early acceptance into med school. It wasn't the 6-year programs that you hear about. But basically, if you got accepted, you were guaranteed a spot in med school, and then you could just enjoy your undergraduate years. And I think we were told, I was talking to someone who had also been in that program. I said, oh, we just had to pass the MCATs, right? And he said, no, I think they just wanted us to take the MCATs. They didn't even care if we passed. So I don't remember that part. I thought we had to at least pass it. But so anyway, I did get accepted into that program, and it was an absolute gift because it really meant that I didn't have to spend the next, 3 years, the rest of my undergraduate years, trying to fit into, the program for applying for med school, right? There's a certain, you had to take a certain course load, but then also, the activities that you put yourself through, just to make yourself look like a viable candidate. I see people doing that as they're applying to med school now, and just the reality of things. And I was spared, fortunately, and I could just kind of dive into the rest of my undergraduate years and enjoy it. And I decided at that point that I would pick something that I knew absolutely nothing about. So I was already a biology major, and I just wanted something that would challenge me and be in a field that I had zero knowledge of. So I picked the classics and ended up in the classics department doing Latin and Greek. And I had a wonderful professor who was also my advisor. And because the classics department is so small, basically I ended up having almost one-on-one tutorials with him most of the time. I mean, a big class for me was maybe 5 people, right?
Wow.
So I got to know my classmates very well, but I also really had one-on-one sessions with this person for 3 years. And he really taught me how to think. He was the person I credit for teaching me how to think, right? So I don't know, people ask me what's the best sort of pre-med thing to do, and I will always say, go do the classics.
That's amazing. It seems like something that once you learn will help you through all facets of life.
Yeah, because I mean, we were doing a lot of translation, obviously, and he was very attentive to the text and making sure that you didn't ruminate or speculate outside the text, at least in translation, right? And then to look at the cultural context and the context of the time, which is something I find that sometimes is missing today, that people forget that there's a certain cultural context and there's a time context, right, where we are in history, so that how we see the world today didn't apply, maybe 50 years ago. So, I mean, just appreciating that our thinking, even as a civilization, that is changing and evolving at the same time.
Yeah, that's a really good point. Well, when you transitioned over to med school, not only did the classes get bigger, but you also started your career as a vandal. You were accused of some vandalization. Can you tell us about that experience? I love the story.
Yeah, it didn't fit in. And I, like you said, the big classes were rather overwhelming. But the other thing was we were crammed into this room, and really from 7 till 5, I think, every day. It was just lecture after lecture. And it was almost sort of drilling stuff into us, and there wasn't a lot about exploring the ideas, and I understand that there wasn't time in the curriculum, but it just got to rote learning and memory work, and I have a very good memory, so that's fine. I could just have relied on it, but it just felt like I wasn't really applying my brain. And I really wanted to do a deeper dive in some of these things, but we were just basically, I think the idea was just to memorize and get through the exams, right? And so, and there wasn't, I'd spent all this time, especially in that first semester, and I realized that for weeks and weeks and weeks, I hadn't seen anything beautiful, right? And then that just, and then I remember running off during class and going to the Museum of Fine Arts, take the bus there. And I just spent the afternoon there just because I needed to just be outside of that whole cram environment and look at beautiful things, right? And And then, as I said in my first episode of the podcast, I was in the dissection lab late one day and looked up all of a sudden and just suddenly saw things differently because this poem came to mind. And it just suddenly clicked in my head for me. And I was really excited because the first time I truly connected with what was going on in med school. So I rushed home and I got these big plastic sheets and colored markers, and I wrote out this poem. It's a very long poem, actually. And I wrote it all out and then dragged it all the way to school the next morning into the dissection lab. And we had these big glass windows all around. And I basically plastered the window, right? Just kind of all the different stanzas of the poem going around. And just when I finished, it was a perfect moment because it was sunrise and we were, pretty high up. And the sun was just coming in, and the colors, because I'd used different colors for those markers, and this poem was dancing, through the window, and there were these amazing cadavers laid out. And it was just this moment that kind of came together for me. And then I went down to class, right? And then, as I said in the episode, the security guard came up and basically reported. They said there was a security breach and someone had vandalized the anatomy lab. And so I turned myself in, and they tried to be nice about it, but at that time I think I was young, and I think I was just so done with them, right? At that point, because I was trying to explain what it meant for me and what I think we hadn't been seeing in all those months so far. And I don't think they got it. And so I just kind of said, right, I'm going to do something else. And actually what I did, I didn't talk about this, but I just basically looked at my schedule. I said, do I really need to be here? No, really what I need is, I just need to pass all these exams. So I took out my calendar and marked the exam dates. And then back in those days, they had these special courier services. I don't know if you heard of them, like DHL and so forth, these different SkyPack and so forth. And what they would do is they would send documents, let's say over to Europe or elsewhere in the world, but they needed someone to actually, they put them in a bag, but they needed a live passenger to check that bag in with. So if you were willing to be a courier and you paid $50, you could only carry hand luggage, but you could pretty much go anywhere in the world. So I said, and all I needed was a passport, hand luggage, $50. Okay. And that's exactly what I did. So I remember walking into the office the first time. They said, where do you want to go? And I looked up and Amsterdam. Yeah, that's where I'll go. Yeah, right? So I did go to Amsterdam. And then I would come back and make the exams, right? So I would go back and forth. Doing that. And so much so that by the time I went into my clinical years, the third year, a lot of people asked me, did you just transfer? And I was like, no, I've been here all along, but I just didn't go to class.
Nice. Wow. That's amazing. Thank you for sharing that story. That's really meaningful. I think that's the best vandalization I've ever heard of. And that's a great way to approach that opportunity of a place that you didn't need to be. So you just leverage, what you had around you and got to check out the world and pass your exams. It's absolutely amazing. So those early years in clinic, bright-eyed, bushy-tailed, you're just out of school. What are your expectations, especially when it comes to what you were kind of specializing in, weight control, obesity, like chronic disease? What were you expecting at that time?
So at the time, I thought I was going into infectious disease. Everyone who knew me in med school, I said, I think I'm going to the London School of Tropical Medicine after this. That's what I wanted to do. Oh, Walter Reed, something like that for infectious disease. I was at Boston City Hospital. So, we certainly saw our fair share of infectious disease. And initially, that's what I thought I wanted to do. But, I have to say, I really enjoyed my clinical years. It was very different from the first 2 years because now you had live interaction with patients, and I was in a very quirky environment. City Hospital was just this quirky place with brilliant people, but they were oddballs like me. And so, and the patients were just as fun. So I really enjoyed, I really made sure I did as many electives as possible. Most people wanted to go elsewhere for and I just said, I'll stay here. I like this place. And then I also did as many international electives as possible. So I spent 2 electives in Brazil, one in the Amazon region and one in the interior part of Brazil. And then I did 1 month in Nepal, in Kathmandu. So having that international experience was really eye-opening, just seeing, the kind of healthcare that people got in other places, what was available, very little generally, right? And I remember in the hospital, it was in Belém, the town of Belém, which is right at the mouth of the Amazon River. And in the hospital there in the morning, the clinic, right, the gates would open and you'd easily have 60 patients, no charts, and they've walked for miles, and you just had to figure out what was going on and try to help them. And oftentimes there was nothing you could do.
Yeah.
And it was similar in Nepal. So, I was in the obstetrics department for a little while and went through surgery department and medicine. But sometimes these women would have walked 2 days, to get to the hospital, and maybe their babies were stillborn already, that kind of thing. It was very,
Wow.
very common. Yeah. So it really was a profound experience for me, just to experience what other people in different parts of the world had in terms of healthcare, right?
Sure.
So yeah, I think that was probably the clinical years, especially the international electives. I really got a lot out of that. It made me think about what it meant to be a healthcare provider. And I have to say, Casey, when someone's looking you in the eye and you're their last hope and you have nothing for them, it's hard to sleep at night.
Yeah, that's tough. Wow. No, I've lived in Brazil. I spent 2 years down there, and I was in the southern part of Brazil where it's a more wealthy area. And,
Yes.
and the way the Brazilian healthcare worked back then, you either had to pay, if you were wealthy enough, you could pay for private care. And that was
That's right.
pretty good from what I remember. Or you could do the free government care, which was atrocious. You might wait like months and months with like a broken arm or something that couldn't see you or help you or had terrible resources. The hospitals were way overcrowded, very dirty. Like it's a totally different thing than what we have here.
Yes, I was working in the public system, and most of the doctors would have their own private clinics because they had to make a living. So basically there were no doctors. There would be 1 or 2 residents. There were no nurses. So I remember in pediatrics, the mothers usually stayed and they did the IVs and so forth. I mean, it was chaotic a lot of the times. So yeah, where in Brazil were you?
So I was down south in the state of Santa Catarina, in the city of
beautiful
Florianopolis.
state.
It is
Oh
gorgeous.
yeah.
Yeah.
Okay. Yeah. So yeah, and it's, the South is a lot more organized, I
It is.
think, than some parts in the North. But yeah, in the public hospitals, it was really heart-wrenching sometimes.
Yeah. Yeah, I remember seeing that. It's weird down there too, because there were so many German immigrants that left Germany during the war. And so
in the South, yeah.
Yeah, absolutely. And so my first city, I thought I stepped off the bus in the wrong continent. Like everything was German. People would talk to us in Portuguese, but then yell at their dog in German. It was very meat and potatoes, and all that architecture was very strange.
And they'd have these little chalets and things like that, right?
Yeah, totally.
I know.
Totally.
Santa
so different.
Florianopolis,
yeah, nice. That's great. Yeah, I have fond memories of that, actually. In fact, if for anybody watching, you can see the painting on the wall is of the bridge in Florianopolis.
Oh wow!
Yeah, I got that down there. So I'm curious. You mentioned dealing with these people as they were in clinic. You might open the doors and there might be 60 people there. What were they presenting with? What kind of care were you providing for those people?
I think oftentimes it was palliative, or just as much comfort, human comfort you could give, because it we didn't have a lot, and people would present with infections, and then maybe we had a few antibiotics that we could use. A lot of times they present with tumors, end stage, or huge, masses that had been growing over time and so forth. So it wasn't stuff that you saw back here. So it was quite different. And then what could you offer them, right? I mean, there weren't that many surgeons in the area, and you couldn't get everyone in for surgery. You couldn't even get imaging, right? So
Wow.
that was, yeah. And there was one clinic that I was in, and the doctor there, he was the radiologist, he was, the ER person, he was the primary care, and he did surgery. And I said, so are you a surgeon? He said, no, I trained as a radiologist. I said, oh, what? You just did a C-section. He said, oh yeah, you know what I did? I went to Sao Paulo. I spent 2 days and I learned how to do it. He said, because there's no one else here. And so he had to. So he says, yeah, I just, I said, hey, can I learn how to do this? He went down to Sao Paulo, some hospital, and he learned how to do it. Appendectomies he's done. And, he taught himself everything.
Wow.
Pretty much, because he was it.
Yeah.
Right. And spending that the night calls with him. Yeah. Anything could show up and you were it. Right.
Wow.
So, that was amazing. And just watching how he just dealt with it, and he just kind of, and like I said, sometimes you have nothing to offer but human comfort,
Wow, that's amazing. Yeah, no, I just, obviously that's way less than ideal, but knowing Brazilian people, that doesn't surprise me at all, that they would go to that length and do something very risky to try to help people. I think that's, yeah, it tells me a lot about them. And was my experience from being down there. When did your focus shift then to more of the chronic disease and obesity side of things?
It was really, so when I was in residency, I thought I wanted to go into ICU, because I really enjoyed intensive care. I think it was that sense of control, right? In the ICU, one nurse per patient, or maybe 2 patients, right? And then all your orders get carried out very quickly, and the labs are really quick, and so the sense of control. Whereas when you send your patient out into the world, you don't know whether they're doing what you ask them to do or not, right? So I thought I would go into ICU medicine at first, and then I decided, no, let's just stick with general internal medicine. But very early, I got to work in an obesity clinic. And it was because a bariatric surgeon who knew me from my training days, he just didn't want to see clinic patients. He just wanted to surgerize them. So he said, and it was fine, because he was good at what he did. And he said, look, you're better off at this than me, right? So he offered me his clinics, and I ended up seeing patients who, either were preparing for surgery or had surgery, or some of them just, chose to do medical weight loss, right? And that actually was another eye-opening experience, because for the first time, I found myself taking patients off medication. And I remember the nurse telling me, hinting lightly to me, you might want to consider going down on the insulin. And I just looked at her and I thought, go down? I've never heard of anyone going down, right?
Wow.
I remember that first week that I was there. And then I got hooked. I'm like, yeah, go down. Everything should go down, right? Because I just realized, yeah, because every time, I saw a clinic when I was in training, and also the brief 2 years when I was doing primary care, it was just adding more medications, increasing doses, right? And at some point, it'd be ridiculous. Somebody's on 15 meds, and this one's for the side effects of that one, and that one's for the side. And I'm like, are we really doing anything? So, it got addictive, taking people off medications and seeing real improvements in their health, noticing that people moved better, slept better, had better quality of life, right? Do things that they couldn't do before. So
Wow.
that was when I realized, oh, this kind of medicine is for me. But it also struck me that we had never been taught any of this in med school or in training, right? They never taught us to de-prescribe because there was not even that concept, right, of de-prescribing. So that you already know you're in a bad place when they can't even conceive of that, right? And then the idea that we can optimize our health, but then it made me realize that the only way we were defining health was absence of disease, which is a pretty low bar, right? I mean, health, what's health? Oh, when you're not sick. Like, ooh, that's pretty bad, right? That's a low bar. And then so when there's no agreement and no clear idea of what health is, then it's really hard to aim for it because it's very fuzzy.
Yeah. How do you define health? Do you define health any differently?
I do. So one of my favorite scientists is Ruslan Metchkov, and he is an immunologist at Yale, and he has talked about health as having robustness and resilience, right? Robustness in the sense that you don't easily get taken down or you don't get sick easily. Resilience, if you do get sick, that you bounce back, right? Easily. And I would add that, that in between that you have, what was the term? Because I've been thinking about this quite a bit. You have options for responding to your environment, right? And I put that other R in, responsiveness to your environment, because we are in a healthcare world that is reactive. But I think when you are in a situation of real health, that not only do you have robustness and resilience, that you are responsive to your environment. And we were built that way. Our bodies are built that way. We have, some people term it metabolic flexibility, but we have this ability to respond to the environment and adapt. And I think a lot of times we forget how amazing we're built, and how the body's made to respond to different circumstances, changes in the temperature, changes in nutrition, and so forth. We have that range.
Yeah, no, that's beautiful. I think about our evolution and how we were able to use technologies to help us. And our bodies are, relatively speaking to other animals, maybe a little weak. We don't have, we can't run as fast as jaguar. We don't have the same fur or power as a bear. Like, there's certain things we don't possess, but yet we, through those 3 R's, we're able to evolve by using our brains and by using technology and cooperating, communicating with each other. I think that's wonderful. I think that's a wonderful definition of health. I want to go back to what you were doing in the beginning with obesity, seeing success, de-prescribing. What were you doing that was different than what other people were doing?
Well, actually paying attention to nutrition and realizing, that it has an impact on how your body functions and on your health, right, overall. And everybody would say that, counseling, nutrition and lifestyle, but that was always kept that way, nutrition and lifestyle counseling. It's such a fuzzy, category. And what exactly are we counseling? Oh, no instructions there. And then what lifestyle behavior modifications are we telling them to do? Oh, we don't know either. And by the way, we're, as healthcare providers, among the most unhealthy, within the population as well. I think definitely in terms of mental health, because I think it's 400 physicians kill themselves every year.
Wow, that's so sad.
And that's 2 med school classes, right?
Wow.
So mental health is very poor in healthcare providers. And, I think there's a lot of burnout. We've heard a lot about that, right? So this makes my point, because I think you might have heard the story, but I got to a point very early in my career where I burned out. I was 2 years out from my training in residency, and I realized I was completely burnt out. And at that point, it struck me, oh, it doesn't matter what you did in the past. you can't last, right? You've got your career ahead of you, but if you can't last that long stretch ahead, you're not going to make it. It doesn't matter that you have an MD. Who cares, right? And then it struck me that, okay, I'm a doctor. I'm sitting here. I'm supposed to help people get healthy. And I don't even know what that means for myself. So that was something, I just didn't feel good about, because I just felt like, would you go to a dentist who had rotting teeth? Right? I mean, I would think, well, you know what? If you can't take care of your teeth, I don't know if I'll trust you with mine.
Yeah.
And that, I remember thinking that and going, yeah, that's just, it's hypocritical to be talking to patients about their health if I'm not able to achieve health for myself.
Yeah.
Right.
Well,
And that's when I quit my job at the time. And it was, there were serious consequences, and it was a hard time for me, but I just realized, that I wasn't any good to patients anymore because I was so burnt out. And at that point, you might be doing more harm, because, when you reach the point where it's hard to care because you're so tired, you have to consider the harm you might be doing.
yeah.
Right. And I just decided that, okay, at the very least, don't do any harm. And then I had to figure my way around that and learn to be healthy, figure out what it means to be healthy. And how come they never taught us this? They
Yeah.
still don't, I mean, they often will say, and this is always, again, oh, these poor physicians are burning out. Oh, we have to counsel people about lifestyle and behavior. And it's just talk, because there's no curriculum, right? I mean, we can't even agree on what health is, right? So basically it's just blah, blah, blah. And I've just gotten to the point where I kind of, I don't listen to that very much, just because, it's not actionable.
Yeah. No, that's a really
Right.
good point. And people make the argument that doctors need to get more of that lifestyle education, which of course they won't. They need to get more nutrition education in school. And initially, I'm like, yes, I'm on board. That would be great. We need to teach them more of that stuff. But the problem is they would probably be learning all of the wrong things anyway. Teaching them might only reinforce the wrong information even further. Like it's almost to some extent better the doctors that get to where you get, where they burn out, they have to step back from the system, and they have to discover a new way that's outside of that paradigm. What do you think about that?
No, I totally agree, because that's one of the reasons, when I started my practice, we made a decision not to hire nutritionists or dietitians, because I actually went through different schools of nutrition, looked at their textbooks, and I just wanted to know what they were learning, and it's not their fault, because they're paying money and they're bright people, but that's the curriculum that's presented to them, right? And so I went through the texts, their recommended texts, the books that they use for their semester. Some of them had their course notes online and so forth. So I looked through all of them and I realized, yeah, no, you know what? You're better off hiring someone with the right attitude and training them yourself, which is what I ended up doing. And then obviously I had to learn myself, but where to start, and then going back to biochemistry and really now connecting the science with the clinical aspects, right? Because it's not just passing the exam and cramming this in and memorizing how many ATPs are formed in this cycle. It's understanding how this relates to what happens in your patient.
Yeah.
Right. And making that connection, I had to go back and do myself, which is one of the reasons I started the podcast, is because I wanted to share some of the things that I had learned. I really had to put myself back through school again and go through the material, update myself, but also now with a clinician's point of view, look at how I can extract clinically meaningful information to use in my day-to-day practice with my patients.
Yeah, I love that. And look, I'm not a dietitian. I'm a nutrition coach. I have a certification that I pass off. There's a giant textbook behind me that I have to know pretty well to be able to continue to be a nutritionist. And really, there's one sentence. There's one sentence in the entire 600 pages where it says anything about the metabolism of fat burning and ketones. There's one sentence. It doesn't say anything other than in this state, you're burning fat and you produce ketones. And that's it. And so like, give me a break. Like, this is a huge, major metabolic pathway.
But it got one sentence. I think that's I suppose progress.
Oh man, I learned more from reading George Cahill's studies in the 60s with fasting, where he talks about how the body keto does. You learn more about that reading a few pages than you do the textbook.
And Casey, this is the sad part, right? Because the information is not, it's not like we've just discovered this in 2021. A lot of this information is from the 50s, from the 60s, right? It's old information. Why is it not in the curriculum? Because you can say, well, newer science, it takes a while before. No, I'm like, no, sorry, we're 50 years behind, and it's still not in the curriculum, because I check all the time. I always ask, I know some students, current students in med school, and I always ask them, send me your curriculum. Okay, well, how are they teaching atherosclerosis? Send me your notes. So they do. And you realize, okay, yeah, we've not moved very much, really. And, none of this information is new. In fact, it's very old. Then you have to ask yourself why it didn't get and still doesn't get into the curriculum, because it's not promoting the paradigm. Nobody gets paid till you get sick. And when you go to med school, basically it's a trade, right? Let's just be blunt. It's a trade. You've got to make a living from it, right?
That's right.
And at this point in time, we make a living off of sickness. We really do.
Yeah.
Right?
Yeah.
So why are we promoting health? You would run out. I mean, that's the worst business model given what we're doing, right? So I definitely think that the reason we don't prioritize it, still not in the curriculum, is because the current model for reimbursement is only for sick care. I mean, I like to joke because, in ancient China, right, the emperor's physicians were basically responsible for taking care of the emperor. And if he got sick, off with their heads. Because, the thinking was, the guy got sick under your care. What kind of physician are you?
Wow.
Right. And that's a whole different motivation going on there, right? Whole different incentives now, because your job and your expertise is to keep the person well.
Wow.
And if he got sick, you were a bad physician. That's a whole different way of thinking.
Wow. That's
right?
amazing.
Imagine if people, imagine if you didn't get paid, or you had money deducted, right, from your payments if your patient got sick. Right? At least the mode of thinking, the way we approach the problem would be different. I'm not saying it's practical maybe to do in real life, because you can't control what the patient is doing, and some things are out of your control. But my point is that the focus now is still on, okay, when they get sick, this is what you do.
Yeah.
Right. And then the expectation, we don't actually say this, Casey, but it's implied. The expectation is they will get worse. 100%. They will get, okay, oh, now you have diabetes. Oh, well, it's just going to get worse. We'll control it now you have high blood pressure, but at some point we'll probably need another medication on top of the one that you have. I just had a patient, and he had, just borderline, chronic renal insufficiency, right? Stage 3. And they're like, well, this will progress for sure. And I was like, for sure? I've taken people stage 3, stage 4, and they've just normalize their renal function, right?
Wow.
But the expectation is that, okay, all right, now you're sick, and we dive in, and you're going to get worse.
Yeah.
And then we'll just add stuff. That's the implication, even though it's not maybe verbalized.
Yeah, no, that's right. And you mentioned diabetes. I think that's probably the best example. We're measuring your blood glucose. It's in the 90s, so you're fine. You can keep doing what you're doing. Come back a decade later. Oh, it's still in the 90s. You're doing fine. Keep doing what you're doing. It's the rising insulin. Your insulin's going sky high. You're not looking at the insulin. You would have known 10 years ago, 20 years ago, that there was an issue, and it's only when the glucose is now out of control and can't get back down.
Yeah.
Let's give you some insulin. Great. Good idea.
Right. And it's very hard sometimes to talk to colleagues because they'll just say, oh, but the glucose is fine. Right. And you're like, well, okay. But at what expense? Right. And it's really hard for people in the medical world in general to grasp that concept, because when I talk to other physicians, because we have patients in common, so I'm, giving them a courtesy call or we're consulting, and they'll always say, but the glucose is fine. There isn't a problem. And I'm like, I don't know what to say, but I don't have 3 hours, right?
So frustrating. Frustrating. Well, I just got back from low carb Denver, and I'm in a room of 1,000 people who mostly believe that weight gain, fat gain, obesity, diabetes, all this chronic disease is related to insulin, and in particular, lots of processed foods and carbohydrates. We had a presenter that came on stage, very well known. If you think you know who I'm talking about, you absolutely know who I'm talking about. And he got on stage and really made the case that all you have to do is really control for calories. Whether you're eating a high amount of carbohydrates or a high amount of fat, it's possible to lose weight and lose fat on either one, as long as you're controlling calories. We're talking about the mechanisms of fat loss, weight loss, dealing with obesity, and all those other chronic diseases, like I mentioned. What do you think? What have you noticed? Where are you on that spectrum?
I think that there are, obviously, and I think you're aware of that, there are hormonal implications, right? That we tend to discount in the general medical, conventional medical world. So we're just looking at a numbers game. And by the way, these numbers are not, they make it sound like it's very scientific, but they're not, because we're not a closed system, right? And also the other thing is we're measuring energy in terms of calories. And as I said in my first episode, there are other ways to think of energy management, right? In the flow of electrons, in the flow of protons, and that's very, very important. Okay. I didn't say this in that episode, but we only focused on the calories, and sometimes we just only focus on ATPs. But, really the flow of electrons, the flow of protons, that's a huge implication there. And when you look at something like cancer metabolism, the cancer cell isn't saying, well, I'll get more calories. It's going, I need to build because I'm making more cancer cells. Okay. And yeah, maybe I get a little less energy here, less ATP here, but I'll get a lot more carbons to use. I can make more nucleic acids. Okay, so it's making that kind of decision. So energy management and regulation is absolutely what metabolism is about. It's just how we think of the energy. And now we're just focused on, it's X number of calories, right? That cancer cell may be saying, I don't need the calories. I need the carbons. Okay, that's a resource. That's energy for them, right? In a different way. So learning to think about it differently is important. And, that's why I think we need to start to have a serious curriculum on metabolic health. Because right now, to me, I think it's still a little fuzzy. And, to be honest, there is the low carb world and then there's a conventional world. But as human beings, we are going to run that whole spectrum under different circumstances. And your body is never static. And at any point in time, you're probably managing a few processes. So I think people don't realize that, for example, it's not like we completely shut off insulin. If you're not a type 1 diabetic, you're always making some basal insulin, right? But you're also making some very, very, very small amounts of ketones, right? And it's differential. You might be making more, to use under certain circumstances at different points in time in the circadian rhythm, but we are not monitoring for this. So we just have a black or white, no ketones. Yes, we have ketones. I'm like, no, it's always going to be the spectrum. Yeah. And there's a balance of inflammatory environments and anti-inflammatory, because again, we're used to thinking anti-inflammatory is good. No, not really, because then you would be immunosuppressed. If you were 100% anti-inflammatory, we need some of the inflammatory responses, right? And what people don't talk about, for example, with circadian rhythm, is that your immune system has a rhythm to it, and we're more revved up in terms of the immune system at night, right? Melatonin, for example, revs up the immune system. Okay, and people don't talk about this, but we need that because that's where your tumor surveillance is coming from. Because when your immune system is slightly revved up, it's looking around, say, oh, tumor cell out, right? And shut it down. So that's, we need some of that. And there's a rhythm to that. So, but that, it's a flux. And it's having people, my goal, actually one of my goals in the podcast is to try to get people away from the polarized thinking, yes, no, black, white, because we have this nuance and this range, and that's why it's so amazing. You have this flexibility in your body, and different parts of your body may be doing different things depending on the tissue, right? So that kind of nuance, that kind of context, we have to take it into account. And sometimes I find when people get into these discussions, we're making it to be all or nothing. And we have to stop thinking that way. It is easier and it's tempting. But when you have a patient in front of you and you're trying to optimize, and you also realize this person is going to go through different stages, right? And, when a postmenopausal woman and someone who's pregnant, right, or in the preconception stage, these are all different phases. Might be the same person, obviously, but same genes, right? But, it's a different context, and your body will start adapting depending on what it needs for that context, and it will shift. And again, it's not going to shift completely to one direction or to another. It's always going to modulate and maybe have a little bit more expression of one state than the other in certain tissues. That's the other thing, right? Because I think the other part that, and I'm going to be doing an episode somewhere down the line, on, for example, insulin, we assume peripheral insulin is the same as CNS insulin. It's not quite the same, right? So, understanding that, and again, we'll just take insulin. We are only looking, I just had a conversation with a physician, and he told me, oh, I was unaware of this. We are generally, even in the low carb, we're only talking about the glucose disposal functions of insulin, right? But it has behavioral implications. It impacts feeding behavior, for example, right? It has proliferative aspects, cellular growth, differentiation. These insulin signaling pathways, it's doing way more than what we generally talk about, right? So insulin in itself also impacts your vasculature and your nitric oxide, and so forth. So when people talk about insulin, I always try to distinguish. I go, okay, we are talking specifically now about the glucose disposal function of insulin, right? And even if you look at the GLUT4 tissues, right? Again, this is where, again, the black and white thinking, and they're like, oh, it's GLUT4. It's like, okay, but they also have GLUT1 at the same time. So if you shut down GLUT4, you still have GLUT1. And under certain conditions, right, you might be upregulating GLUT1. So you have to think about that. And sometimes your body does it on purpose, okay? Because it requires that you have, that you prioritize the glucose for certain cells and so forth, right? So the big picture is you got to stand back. And this is something I was talking to a patient, and he's a systems engineer, and he said he got it immediately. He says, yeah, it's a system. You perturb one part, and there's always, you can't see anything in isolation. And this is where, much as I have learned so much, and I love being in the low carb world, I also think that if you're going to develop this field of metabolic health, and take it to the next level now, right? Now that we've raised consciousness and we've realized that this is important, we got to get this into the curriculum. This is how we should be treating our patients. But the next level is really having a deep understanding of what's happening in the entire system. And when I push this button, all the deformations that happen downstream, right? We have to start to understand that, and not just one cascade, one signaling pathway. There are numerous that will be impacted. I did the mTOR episode, and people were surprised that, not only other amino acids, but cholesterol will actually activate mTOR. Right. And so there's this, you take leucine. Well, actually many amino acids, at least 10 of the amino acids. And it's just a time. Some of them will activate mTOR within 15 minutes. Some will take longer. Maybe glutamate might take 60 minutes and so forth. But, cholesterol itself will activate mTOR. Right. So, and I had pointed out in that episode, all right, we're going to activate mTOR through all these different mechanisms. Then we have to start to step back and look at what we're doing and how it's impacting the mTOR complex. Right?
Wow.
And not just look at one amino acid. I mean, generally people look at leucine, but we know arginine, methionine, and plenty of other amino acids will activate. And then there's the lysosomal, which is what I explained. So we can sense, you take leucine and it gets into your cell, and in the cytosol, we sense the leucine, right? But when you break down proteins and it gets into the lysosome, there's a sensor in the lysosome that will activate mTOR as well, because you've just liberated some amino acids from breaking down some proteins in the lysosome. So that itself will activate mTOR, right? So there are so many components, and we're only looking at bits and pieces. And we need to get to that different level now where we have an in-depth study of the metabolic field, so that, we can push our healthcare towards that system, right? And in a bigger way, right?
Yeah.
So I mean, that's just kind of, you let me rant, so you were very kind.
I'm gonna have to listen to that twice. That was so good. I love that. No, that's amazing. Such a great and nuanced answer. And this is why nutrition can get so frustrating. It's because there are so many different components, and then again, it's like, you're sending patients out into the world, and it's like, what food do you like? What tastes good do you like? It gets down to that level, so it becomes so complex and complicated. But I'm so glad you're willing to go there. I didn't know that about melatonin, by the way. That's fascinating. That makes a lot of sense to me, but I didn't know that.
Yeah, melatonin will upregulate, interleukin-6, for example, and so forth. So you need a little bit of that, rev up of the immune system. You need some tumor surveillance, especially at night. Right. And there's, a clock, obviously, to the immune system. And now at least even in the pharmaceutical world, they're looking at chronodosing. So, maybe giving the medication PM is really important because it's going to impact what's going on through the night, right? So the sophistication now is on chronodosing, because they're recognizing a huge role of the circadian system, right? But, we need to take that into account too, as to what's going on, in terms of use of supplements, in terms of what we're doing at different times of the day.
Yeah, no, I love that. That's a great point, and absolutely fascinating that they're getting more and more into that. That makes a lot of sense. So recently I listened to a podcast that was more kind of mainstream, really popular, and they were addressing the problem of childhood obesity. And they were talking about, I want to say it's the American Pediatrics Association that just came out not too long ago that said, basically at age 2, you can start nutrition counseling if a child is presenting as obese. At age 12, you can put them on prescription medications. What is it? The GLP-6 inhibitors, is that right?
GLP-1, yeah.
GLP-1 inhibitors.
Agonist, yeah.
Agonist, got it. And I knew I was going to mess that up. And by 13, you can start to do bariatric surgery. And this woman who was explaining all this was like talking about the mechanisms of obesity. There wasn't much obesity in the 60s. In the 70s and 80s, it started to increase. We did studies where we went into schools. We told them the best things that we knew how to do to reduce obesity, and against the controls, they performed the same. So now we believe that obesity is genetic, and you can use these interventions at younger and younger ages to reverse obesity. I listened to the episode 4 times. I would finish it and I think like, did she say that? No way. Like, I did go back and listen again and again. What do you think about that?
Well, I will just point this out when I see patients, and they often show me pictures of their family, right? So if I have a patient who has obesity, it's likely you'll see that the whole family has obesity. But one very interesting thing, Casey, the dog is also obese. Now, I don't know if they share genes. Do you think the dog shares genes? I want to think about that one, right? I mean, I was like, what does your vet say? Oh, he needs to lose weight. Must have your genes. I don't know. I mean, that's just sorry.
That's a great point.
I couldn't resist. But I see this so often, right? They have a fat cat or they have a fat dog, right? And I'm like, well, I don't think we're sharing that many genes, are we? But I could be wrong. I'm just a human doctor, right? So, I think we're getting ridiculous now, really. I mean, that might not be popular, but that's what I think. I do think it's getting ridiculous. And throwing medication and, going after weight, that's the other thing that gets me going there. Because, what you're doing is you're just going after a number on the scale. And if we're looking at the metabolic tissues, and if you're going to talk about metabolic health, you must consider the metabolically active tissue in your body, which is why I think the body composition is so important: fat, muscle, bone, right? I mentioned in one of my episodes, I think it was episode 4, but this is something I keep trying to get people to understand. Look, your biggest sink for glucose is going to be muscle. Okay, you shrink the muscle mass, and now there's less place for the glucose to go. And there's going to be more spillage. It's going to spill, and your fat cells are going to try and mop it up. Okay, but ultimately it's going to spill into the bloodstream. You could be eating the same thing, not change your diet. Okay, this is the part people don't understand. You lose 5 pounds of muscle, you gain 5 pounds of fat, you are weight neutral, and that doctor that you see is going to say, oh, you did a great job, Mrs. Jones. No, you didn't, because you just lost 5 pounds of muscle. And where's that glucose going to go? It's going to go to fat, and it's going to spill out into the bloodstream. And Mrs. Jones is not going to change her diet. She's just going to eat the same thing. But year after year, she's going to notice that, strangely, her fasting levels of glucose are creeping up. And one day she's diabetic. So I have this a lot from people who are healthy, right? And they're normal weight, normal BMI. But, actually they have normal weight obesity. And because they have a smaller muscle mass now than when they were younger, it's less able to absorb the glucose, right? So for the same amount that you're eating, you're less able to handle that amount. And so it's going to spill. So looking at metabolically active tissue is really vital if you're going to talk about metabolic health, because it's not meaningful if you're just going after a weight. Right. So now we have all these people lose weight, and I see this. And in that same episode, I cited a study, from looking at bariatric patients. How much muscle are you losing? Okay, because everybody talks about, and they lose X percent of their body weight, and I'm like, wait, okay, tell me how much muscle they lost. That's what I want to know, because metabolically, it's going to catch up with them at some point. Right. So now we have kids starting off very early. You put them through surgery, or you put them on medications that basically, eliminate their appetite. Okay. So, and I have had patients whose other doctors put them on some of these medications, right? So they're not eating, and they come to me and we DEX them. I follow my patients by DEXA. And so you can watch that muscle mass shrink. The older you are, the more anabolic resistance you have. It's not so easy to hang on to muscle when, you get to your 40s, let's say, right? You're 20, okay, you can get away with a lot. But, if throughout your growth spurt, you're not getting enough protein, that will impact you too. Okay. And a lot of bariatric patients and a lot of people on those medications, I see them firsthand, they're not getting the proteins they need. They're just not. If they're making only one meal and then, they feel too full, right? So A, that's not helpful. And B, we're also not getting to the root cause. A lot people don't recognize that, there's physiologic hunger, and then there are other types of hunger, emotional hunger, for example, right? And so we're just assuming this is purely physiologic, right? And, we know that patients who've undergone bariatric surgery, their risk of depression goes up, risk of suicide goes up.
Wow.
Risk of alcohol addiction goes up. Why? Because that food was doing something. It was soothing them in some way. It was filling a kind of hunger. Okay. And sometimes my patients, when I've started them on, they'll go, I didn't feel good. And I'm like, yeah, well, I took away your medication.
Wow.
Because, when you were stressed, that's what you used to do. And they're like, oh my God, you're right. And I'm like, yeah, I just took that away. So of course you don't feel it. Now we have to find other ways to feel good.
Wow.
Right? That's the harder path. But, we're not going to talk about that because that's more work. Right?
Right.
And that means dealing with the person, as a human being. And not dealing with a number on the scale, because right now we can congratulate ourselves over the numbers on the scale. Okay. But if this person now has been hospitalized twice for depression, has a suicide attempt, now is addicted to alcohol, I don't know. Did we do anything? We probably made it worse.
Wow.
Right. So those are the issues that are not discussed. Plus, again, how this impacts development if we're talking about pediatrics, right? And I'll tell you, I have patients who have had surgery, and they'll tell you, oh, you find a way around it. They're the first to tell you. They find a way, they find the tricks around dumping, they find tricks, to get in what they want to get in.
I've heard that actually.
It's a very common. I see these patients my day to day. Right. And so it's, I don't know, when you're frontline and you're looking that person in the face and you're not staring at a computer screen, that's a person in front of you, and they have, real lives and real problems. You realize, what, you're not going to solve the issue like that.
Wow.
But we like the quick fix, and we like the number on the scale. And you just go for that number on the scale. We already have sarcopenia. And actually, most patients have osteosarcopenic obesity, fat, muscle, bone. You cannot talk about metabolic health without talking about fat, muscle, bone. And when you look, they have osteosarcopenic obesity. Now, fat, muscle, and bone, we think of them as different tissues, but there's a lot of intertissue crosstalk. And, hormonal signaling, paracrine and autocrine signaling. So when we say hormonal, it goes into the blood and things like that. But paracrine and autocrine, meaning that locally, right? So bone, for example, is signaling to muscle that's attached to it. And that's local, doesn't necessarily have to go into the bloodstream, right? So there's a lot of crosstalk between these different tissues. And you'll see that if you shift the percent body fat, you're going to shift the bone, you're going to shift the muscle, right? And we have to now manage this composition and find the optimal composition for the patient, right? But that's again, it's very simplistic, number on the scale, BMI, and done, right? But if you start to talk about, and then fat, I know you wanted to ask me about fat, and yes, there are different compartments of fat. There's, the subcutaneous, there's the visceral fat, sure. What I didn't say in that episode is, I said it, but I hinted at it, is like the subcutaneous fat on your hips may be different from the subcutaneous fat on your back. So even white subcutaneous fat, right, depending on location may be different, right? So there's that level of complexity. Then you have the different, beige and brown and white and pink, right? Which, because breast tissue also very, very plastic, the fat tissue there, right? Because we've always assumed that, fat cells, eventually they die, they become fibrotic and so forth. But, at least definitely in breast tissue, fibroblasts now revert back to fat cells, right? And there's this range that they can accomplish, okay? So there's that. Then we didn't even talk about bone marrow fat. Very, very interesting because it affects beiging, it affects brown fat, right? And brown fat impacts bone density. This is also not new, right? But bone marrow fat, I think, is really fascinating. And this is this weird vascular niche. Yes, it's in the bone, but it's in its own niche in some ways, So there's that component of fat, right? Then, what the fats do, what they can secrete, the hormonal aspects, the cytokines that they can secrete. Everybody talks about leptin. Leptin is actually a cytokine. I never hear that mentioned, right?
No, never.
It's in the yeah, it's very, similar to interleukin 6. So it's a very inflammatory. Okay. Cannot talk about leptin without its inflammatory aspects and its relation to the sympathetic nervous system. Do we ever talk about it? No. Right. And I'm just fat. I mean, you go to muscle, you go into bone, right? And so that's the basic of metabolic health: fat, muscle, bone. And then you want to talk about disease conditions like atherosclerosis and Alzheimer's, and that is a different level too. But at least the basic, we have to start somewhere. And for me, the basics would be fat, muscle, bone, knowing that axis, really knowing intricately how it's impacting the other components in the axis, right? And of course, it all talks to the brain, right? Fat, muscle, bone, they're constantly signaling. Fat, for example, a lot of energy regulation is through fat signaling to the brain and then having, downstream effects, right? So, I think that we are, I think what we need to do now, Casey, at this stage is really develop this metabolic health world. It's got off to a good start and we're starting to get some traction, get people at least involved, interested. And like you were at Low Carb Denver, so there's a following now and people understand this. And, now so we got to the threshold, now we can peer through the doorway and see the world that's before us. And that's a different way to look at the body. That's, to me, how we should, going into this century, deeper into this century, that's how we should be looking at the human body and looking at a medical treatment through the lens, through that doorway of metabolic health. That's the new path of discovery for us, right? And when people talk about changing the system, changing the paradigms, you ask me why I started my own practice. You can't build something new from within something broken. A broken system usually doesn't allow something new and fresh to come out of it without squashing it, right? So I felt I had to step out of that. And my mentality when I stepped out of that was to say, let's start from scratch. If I'm going to step out of the system, let's just start from scratch and say, if now I had to build a medical system, what lens would I look at my patients through? What would that curriculum look like? How should we approach the patient? I know I learned all that stuff in medical school, so I know what that looks like, right? But now if I step outside of that and you say you want to build something new, then what's new about it, right? And this is how I think, so, I was very naive, but I'm still keeping my fingers crossed. I was hoping to build a parallel universe to the current medical system, right? And then basically let patients decide which they prefer.
Wow.
You know, because we only have one option right now. So let me build a parallel universe to the current, you know, industrial complex that exists. So that was the dream, right? And I needed that knowledge base. And so I had to put myself through that learning process from scratch. And, you know, I'm not ashamed to admit I had to start from scratch. I didn't learn it in med school, you know, so it was very humbling. And it was just from saying, I don't know, and I need to learn if I'm really going to help someone.
Wow.
So
Wow.
putting myself through that, trying to read, trying to understand, looking at the patient and thinking a zillion times, and not only thinking from one aspect, right? So thinking through all aspects. So, you know, okay, you take something like intermittent fasting, okay? It has benefits, but it has some cons, because as my patient is aging and has anabolic resistance and either has sarcopenia already or is at high risk for sarcopenia. Now, how am I going to get the protein in the time that I have, right? Knowing that we need to bolus, right? To get a certain response in muscle protein synthesis, we have to bolus the protein. You can't like straggle the protein in through the day, right? So how do you do that and you know, make that work in the context of intermittent fasting?
It's hard.
So that's a real life, yes, because you sit down and crunch the numbers, because that's what I did. I crunch. You know, I was like, okay, I'm not smart enough. I asked Driss, who's you know, my operations manager, and Driss has a PhD in theoretical mathematics. I said, Driss, can you make this? He's like, no. Right. So I'm like, okay, the smartest guy here couldn't make it work, right? So, you know, people go, what do you think about intermittent? I said, look, it's useful in certain contexts and I will use it in certain patients. But long term, that's not a strategy I usually prescribe long term. And then people, you know, I know lots of people, and including friends and so forth, they try intermittent fasting and they have lost weight, right? But the general story is they'll stagnate. They'll have a nice, you know, drop, and then they stay, right? And then they start to struggle, especially if they're middle age. And if you're a middle-aged woman and you're looking at menopause, yeah, your body composition is going to change pretty quickly. And you will accumulate more fat, even if you stay the same weight, but you're losing muscle at the same time. Now, you know, I have to look at that context and say, for this person, this might not be applicable. And that's where the nuance now starts to come in. But that's also where I think, you know, we can start to optimize a patient's care. We always talk about individualized, but everybody gets the same thing. No, you know, you have to look at the context and understand and look at it from, you know, a systems point of view and say, yes, you know, and you're not going to get 100%, but you're going to pick for this patient in this situation, in this part of the lifespan, this is how we're going to optimize. And it's going to shift because we're not static. You see, I think we need to stop, again, this polarized thinking and this static as if it's the universe were still, but we are constantly shifting. You see what I'm saying? Yeah. So
yeah.
Again, you let me rant. So
it's so good. There's no chance I'm going to stop you from all that. It's so good. This would be the point of the show where I would put you on the spot and ask you to come back to continue this conversation. And we goofed up. I sent you 2 calendar links that were like a few days back to back. And I was like, hey, which one do you want to do? We can do one of these or the other. And you're like, why don't we keep both? And I'm like, that's a great idea. That is a great idea.
Let's do it.
This is amazing. The content you've given us today is so good. It's so much to think about, yet we're barely scratching the surface. Now I understand why you say that at the end of an episode of your podcast that goes an hour and a half. Like, well, we just barely scratched the surface. It makes a lot of sense.
Yeah, there's so much. There's so much. I mean, like I did the lipoprotein one. And again, you know, that's the other thing. Yeah, we have to watch ourselves and have some intellectual integrity here. Here's what I mean by that, right? We laugh at the people who now like maybe are going okay, you have to lower the cholesterol in everyone, and they use the regular cholesterol panel. And maybe some of us are more sophisticated and we're going after the, advanced lipid panels with the subfractionations and so forth, right? But I go up to people and I go, well, what do you look for in the subfrac? And they say, well, the small dense LDLs are bad. I'm like, okay, they're bad. Like, why? Well, we see that, those are the people who have the highest risk. Okay, yeah, but where did they come from? What makes them different from the not small, dense LDLs, right? And there's no response, right? So then if that's the case, and I was in that category, I was like, oh, that's bad. And I said, but why? I had to ask myself, right? So then we're in the same position of taking a dogma and then just blurting it out without at least knowing why we're saying this, right? So I always watch myself because I think, it's easy to look at someone and say, they're using that old paradigm, they're still bloodletting, they're still focused on cholesterol, right? But then I have to watch my thinking and say, am I doing the same thing? Because now we have a whole group of people who are running around and it's like small dense LDLs are bad. And when I asked them, I said, yeah, why are they bad? Right? And it's hard for people to answer. So this is where, this is an opportunity. It's not saying, I'm just saying this is, if we notice this in ourselves, this is an opportunity for learning so that we can advance our field of metabolic health for all of us, right? And, I do talk about that in the lipoprotein episode, but that was only the lipid transport part of lipoproteins. As I said in that episode, there's a whole nother world to lipoproteins that I want to share, and it's kind of mind-boggling too. If we actually look at our bodies, it's amazing. And that's why I think I brought back that Walt Whitman poem that I started my med school with, is because now, I feel like, in the end that I had chosen the right poem and the right outlook for it. And that Whitman poem, which basically talks about how amazing our bodies are. And it's just, this vibrant poem about the body, and that line of, I sing the body electric. And, if we understand that the energy is in the electrons and the protons and the carriers of those particles, he was way ahead of his time. Right?
So beautiful. Wow. I absolutely love this. This has been so much fun. We are going to turn around and do this again next week. I'm so excited to have follow-up questions. Let's go a little deeper into this stuff. But for today, this has been incredible. Such a great discussion. I love how nuanced you are and how we really need to individualize care for people. And the industrial system, like you said, just is not cutting it as far as that goes. Dr. Vyvyane Loh, thank you so very much for taking time out of your day to do this. I know you're very busy. Where is the best place for people to go to find you and connect with you and your work?
So my website is vyvyanelohmd.com, VYVYANELOHMD.com. And of course, my podcast is called VLMD Rounds. That's 2 words, but it's mostly my initials, VLMD. And that's why I named it, because I used to sign my charts that way, VLMD.
There you go.
Oh yeah, VLMD Rounds. So
awesome.
Yeah, and thank you for letting me rant, Casey.
Oh, it was so good. I've learned so much. This is definitely one that I'm going to have to go back and listen to again. I know I'm going to have tons more questions for you for next time. It's wonderful content. It's just like your podcast that you put out there. You bring a high level of education, which is awesome, and the mechanisms and all the science and everything. But it's like you said, there is a marriage between the science and behind the and with the practicality as well. And we need both. We need to help people because people are very, very, very sick. And they need this information, but they need it in a way that can actually improve their lives. And that's what you've done. You quit what you were doing to be able to do it. And I just have so much respect for you. And I really appreciate the time you took to be on our show today. So thank you so very much, Dr. Loh. It was a real honor.
It was so much fun, Casey. Thank you for having me.
Absolutely. And this has been another episode of Boundless Body Radio.